Welcome to the deep dive. Today, we are plumbing the depths of, well, one of the most persistent, widespread, and frankly, just bizarre failures of medical science in history.
It really is.
It's a story that perfectly illustrates how a systematic cultural denial can utterly override basic biological reality for generations. We're talking about the diagnosis of hysteria.
Hmm.
And the central paradox here is almost impossible to wrap your head around. Get this. For decades, millions of respectable women across the Western world received medically sanctioned sexual satisfaction.
From highly trained male physicians.
Right, often on a weekly basis as part of their routine care. Yet at the same time, the entire medical establishment insisted with absolute clinical confidence that respectable women had no sexual desire whatsoever.
None.
And this wasn't some fringe practice, this was mainstream, expensive, profitable medicine. And it led directly to the mass adoption of one of the 20th century's most ubiquitous household appliances.
What's so fascinating here is that the sources we have, historical medical journals, patient testimonials that are often really coded or veiled, and the anatomical texts of the time, they reveal this colossal organized system of blindness.
A system of blindness. I like that.
Yeah, we're looking at a system built entirely on cultural bias, where the most educated people of the era were systematically trained not to see the obvious truth that was unfolding right there on their examination tables.
Okay, so let's unpack this. Our mission today is to trace this incredible story. We're going to start with the patient experience in the Victorian era, track the diagnosis back through 2,000 years of flawed medical theory,
A long
a
time.
very long time. Then we'll analyze the industrial scale denial required to keep this profitable practice running for over 70 years, and understand why the entire facade finally collapsed almost overnight.
It's a story that tells us less about medicine and more about the fragility of scientific consensus when it clashes really violently with deeply held social norms.
So let's start not with a dusty medical journal, but with a specific woman in a specific place. Let's put ourselves in a private London clinic in the late 19th century.
Okay.
And you have to try to picture the environment. This is a space designed to inspire absolute trust and authority. We're talking, oppressive heat, maybe the faint smell of burning coal and medicinal oils.
Flickering gaslight casting deep shadows, mahogany walls lined with these weighty, serious-looking medical journals and anatomical diagrams.
Exactly. And our listener, a woman we'll call Mrs. Adelaide Whitmore, is sitting in the waiting room of a Dr. Edmund Carter. You can just see her gloved hands trembling slightly, despite the heat.
And Mrs. Whitmore's experience is heartbreakingly typical of the era. Her symptoms they're vague but intense.
Hmm.
And they are crucially non-physical in the sense that you can't pin them to a broken bone or an obvious infection.
Right. So what is she suffering from?
Well, chronic insomnia, crippling irritability. She reports snapping at her cook over the slightest error, and that persistent, visible trembling in her hands, particularly during formal occasions like afternoon tea.
And the real trigger that finally brought her to see Dr. Carter was a public humiliation. A violent internal disruption she experienced at a high society social function. She describes it as a convulsive sensation, something profound that left her flushed, gasping for air, unable to speak.
Which forced her humiliated husband to just quietly escort her away. It sounds profoundly physical, but completely unlocatable by any standard examination.
She's been to other doctors before this.
Oh, yes. And this is where the medical frustration becomes relevant. She'd consulted several other respectable physicians, but they had utterly failed her. Their best advice was vague and, frankly, useless.
Like what? Bed rest.
Mandatory bed rest, long hydrotherapeutic baths, which we'll get into later,
Yeah.
and these bitter, foggy tinctures designed to calm the nerves that did precisely nothing.
But Dr. Carter was different.
Dr. Carter represented the modern physician. He was reading the latest, most progressive journals from Germany and France, and he approached her symptoms not with vague suggestions, but with this absolute, unflappable certainty.
And that certainty resulted in the confident but chilling diagnosis.
Hysteria.
He pronounced the word, and in that moment, for Mrs. Whitmore, it just hung in the air like a diagnosis of doom, because she knew it meant she was faulty, fundamentally nervous, and prone to collapse.
And his rationale, which he delivered with complete clinical detachment, it just perfectly summarizes the medical doctrine of the Victorian age about women. He assured her it was a fairly common condition in women of your station.
Of her station, so a class thing.
Absolutely. He explained, the female nervous system is delicate, you see, far more susceptible to disturbance than the male constitution, designed as it is for robust action.
And he immediately connected it to the perceived root of the problem.
The uterus.
Right.
He explained that this organ exercises a profound central influence over the entire female system, and that when it is left unsatisfied, when its essential functions are thwarted or its energies misdirected, it becomes restless.
And that restlessness, he insisted, is what manifests as her nervous symptoms. The insomnia, the trembling, the irritability.
The profound irony here, of course, is that Mrs. Whitmore was a respectable, married woman with children.
So she immediately flushes, thinking, unsatisfied. What does that even mean?
Exactly. But before she can object or seek clarification, the power dynamic just dictates she remain silent. Dr. Carter is already gesturing toward the examination screen, ready to move from diagnosis to immediate, established treatment.
Okay, so let's detail the clinical encounter, because the precise protocol they used here is central to how this denial was maintained for decades.
Mm-hmm. She disrobed behind the screen, as instructed, emerging wrapped in a simple white sheet, the standard uniform of modesty.
And the source material emphasizes that the doctor was all business, right? He had an expression of professional concentration, utterly devoid of impropriety. The whole setting was engineered to suppress any kind of human connection.
He had his instruments prepared, which were deceptively simple. A small tray with clean cloths and a bottle of expensive scented oil lavender and roses, maybe?
And the procedure itself was clinical, cold, and critically. It was done without seeking permission or explanation beyond the necessary instructions.
The text notes that he positioned himself and began the application of the oil with these measured, deliberate movements, keeping his gaze strictly focused on his notes or, the ceiling.
And at first, for the patient, it felt exactly like that. Clinical, medicinal. She felt the chill of the sheets, the slickness of the oil. But then the texture and the purpose of the movements shifted.
His fingers began to move with greater purpose, rubbing in circular motions, pressing deeper, finding sensitive points she didn't know existed.
She wanted to speak, to ask him to stop, but the weight of his medical authority was total. She was paralyzed by the formality and just the assumption of his good intention.
And the sensation builds rapidly, becomes alarming, overwhelming, and highly localized. This is the moment documented in the journals when her breathing becomes shallow and ragged.
Her muscles contract involuntarily, and the physician observes this as the onset of the paroxysm, the therapeutic release. The patient's internal experience of that climax is described in these sources as a sudden violent release. Her back arched momentarily off the table. Her hands grasped the edges of the sheet.
Everything just dissolved into a sensation that was an explosion of pressure and relief, and something entirely foreign, something that felt dangerously close to pleasure, a pleasure she was not supposed to feel.
And the medical reaction to this profound physiological event is maybe the most clinical part of it all. It just cements the denial.
Dr. Carter just stepped back, immediately writing quick, detached notes on his clipboard. He declared, "Excellent. The paroxysm was quite pronounced. You should see immediate relief from your symptoms."
And then he gave his follow-up recommendation. Twice weekly for the next month would be optimal.
Just like that. The nervous energy was purged, the problem was solved, and the patient, despite her reeling mind and the deep shock of what had just happened, was compliant.
The fact that he could recommend this twice a week and genuinely believe he was treating a nervous system issue, not satisfying a physical need, it just speaks volumes about the power of medical context.
To understand how Dr. Carter could operate in such a profound state of clinical denial, we have to trace the history of this diagnosis.
Right.
The concept that female nervous collapse stemmed from the uterus is not a Victorian invention. It's truly ancient. It forms the bedrock of Western medical thought about women.
Absolutely. The idea that women were inherently physically unstable, that originated with the Egyptians, who attributed all these female ailments to the uterus.
But it was the Greeks, specifically Hippocrates, the supposed father of Western medicine,
Yeah.
who gave the idea its formal scientific-sounding shape.
And he looked at women suffering from anxiety, melancholy, nervous complaints, and theorized that their internal organs were literally traveling.
And the Greek word for uterus is hysteria. So when we use the term hysteria, we are quite literally saying disease of the wandering uterus.
It's right there in the name.
It is. The original theory was dramatic and deeply unsettling. Hippocrates theorized that if a woman remained unwed or childless, her womb would grow restless. He even said it was being deprived of the moisture it needed, causing it to literally detach from its proper moorings.
And this restless organ would then wander through her body cavity like a lost animal. I mean, just imagine that image.
It's horrifying.
As it traveled, it would press on nerves, on the liver, the lungs, causing symptoms that seemed random all over the body. A sensation of choking when it pressed on the diaphragm, muscle spasms, violent anxiety.
The symptoms were so wide-ranging because, well, the uterus could wander anywhere.
Plato then took that concept and sort of elevated it into philosophy.
He did. He described the uterus not just as a restless organ, but as an animal within an animal, possessing its own life, its own will, and its own intense desires. It was rebelling against the host body if its biological function, reproduction, was thwarted.
Which led to a solution that seemed, in that ancient context, like logic as ironclad as geometry.
The original cure for hysteria was marriage and pregnancy.
Simple as that. Satisfy the womb's reproductive needs, and the woman would be cured of her nervous distress. Her physical complaints would just cease.
Now, here's where the history gets really complicated, and it shows how culture just outlives anatomy. By the Renaissance, medical knowledge finally advanced through careful anatomical dissection.
So actual science starts to creep in.
Right. Physicians like Andreas Vesalius began to prove definitively that the uterus was securely anchored by powerful ligaments and structures. It did not, in fact, wander through the body cavity like a hungry animal.
So we have this incredible intellectual conflict in the 16th and 17th centuries. Physicians knew the anatomical basis of the disease was wrong.
They knew, but they couldn't abandon the diagnosis. The cultural and philosophical inertia was just too strong, so they simply adapted the theory.
How?
Well, the uterus didn't physically wander anymore, but its nervous influence was still considered restless and unstable.
Okay. So even after the original literal anatomical basis was debunked, the idea that female distress originated exclusively from the unstable nature of the reproductive system just persisted.
Exactly. The diagnosis of hysteria simply expanded. It became an infinitely elastic, catch-all diagnosis, capable of absorbing almost any behavior or complaint that didn't align with the very narrow parameters of respectable womanhood.
Just think about that list of acceptable symptoms. Nervousness, insomnia, muscle spasms, shortness of breath, loss of appetite, irritability, even faintness. If a woman had any complaint, emotional, physical, or social, it could be labeled hysteria. It was the ultimate way to pathologize the entire female experience.
And this is where the sexual paradox really solidified in the Victorian period. As our sources show, both sexual frigidity or sexual forwardness could be diagnosed as hysteria.
So it's a trap, a no-win scenario.
It was a complete no-win scenario that guaranteed medical intervention. If you were too sexual, you were hysterical. If you weren't sexual enough, the restlessness of your womb was making you hysterical.
And the scale of this was just staggering. The English physician Thomas Sydenham estimated back in the 17th century that hysteria affected 1/4 of all women.
1/4.
He said it was the most common disease after fever. And if you have a disease that impacts 25% of the population, you are no longer describing a pathology. You're describing a systematic pathologizing of normal human existence.
And this was rooted in an elaborate medical doctrine of female physiology that was taught relentlessly in medical schools.
What was the central idea?
The central tenet was that the female constitution was designed entirely and exclusively around reproductive capacity. The uterus was the absolute all-consuming center, fundamentally subordinating everything else, the nervous system, the brain, the heart, to its reproductive task.
The message to women was clear. You are not meant for strenuous intellectual work or independence or stressful professional life.
Any deviation from that purely reproductive role was seen as dangerous, a form of bodily betrayal that would inevitably result in nervous derangement. You couldn't trust your own body or your own mind because the uterus was constantly trying to undermine them.
They even pathologized normal processes. Heavy, absent, or irregular menstruation was cited as evidence of hysteria.
Puberty itself was considered medically dangerous because it awakened this potentially volatile nervous center. And naturally, single childless women were considered medically at risk. This pervasive, self-fulfilling prophecy just ensured that physicians always found evidence of hysteria because they expected to find it in every single female patient.
This historical context brings us back to the central contradiction of the Victorian era. I mean, it's incredible that this 2,000-year-old theory survived.
It is.
But the truly staggering part is how a highly educated medical profession could spend 2 centuries inducing orgasms while simultaneously denying that female sexuality even existed.
Well, it was possible only because the denial was institutionalized and absolute. And the most influential physician defining this specific doctrine was a Dr. William Acton.
Okay.
In his highly respected 1857 treatise, he stated, very bluntly, that The majority of women, happily for them, are not very much troubled with sexual feeling of any kind.
Happily for them, that quote is critical, isn't it?
It's everything.
Because it confirmed what society wanted to believe. Respectable middle-class women were pure, maternal, angelic. They tolerated sex only as a duty to their husband and for reproduction. If they experienced desire, they were degraded or pathologically ill.
And this doctrine created the profound paradox we see everywhere in the sources.
Yeah.
Physicians acknowledged that millions of women suffered from these nervous disorders requiring intervention, but they remained completely blind to the obvious cause.
That these women were experiencing the physical and psychological symptoms of sexual deprivation and frustration in a society that forbade them from expressing or even acknowledging their own sexuality.
Exactly. So the treatment pelvic massage had to emerge from this fog of contradiction. The internal medical logic was simple. If the uterus was restless and causing nervous pressure and symptoms, inducing a hysterical paroxysm through manual manipulation of the genital region would provide relief.
It would purge the nervous energy and restore order.
Right. But crucially, the entire process was riddled with deliberate mechanisms of denial designed specifically to maintain that clinical pretense and avoid confronting the obvious reality of what was happening.
This is where architecture, protocol, and language become weapons of self-deception. Let's visualize those protocols of denial. The patient was instructed to disrobe from the waist down, but for modesty, she kept her upper body and, critically, her face covered.
Which means the physician wasn't looking into the patient's eyes, he was interacting with an anonymous body part. This physical separation allowed both the physician and the patient to pretend the person, the woman with thoughts and feelings, was not present.
And the setting reinforced this pretense, right? To ensure clinical distance. Examination rooms had high ceilings and were often adorned with highly technical medical charts or anatomical models far from the table, drawing the physician's eye upward or away.
Some offices even used screens or adjustable lighting so the doctor could approach from an angle that minimized eye contact, ensuring the focus was kept strictly clinical and scientific, never intimate.
And the language used by physicians was maybe the most powerful tool of denial, transforming a sexual act into an academic discussion.
Absolutely. They never discussed the experience as pleasure or climax. They focused only on the physical manifestations of the paroxysm, the therapeutic outcome.
We have sources like a Dr. Nathaniel Highmore, writing as far back as the 1660s, observing and documenting this phenomenon, yet totally failing to recognize it.
He described what he observed in this detached clinical language. Violent contraction and relaxation of the muscles accompanied by flushing of the face, a feeling of heat throughout the body, and in many cases a copious discharge of secretions, followed by a state of profound relief and calm.
That is astonishing. That description, the muscular contractions, the flushing, the copious discharge, the profound relief, is clinically and physiologically a perfect description of a female orgasm.
It's a textbook description.
And yet, they could read this, publish it in medical journals, and genuinely not recognize it as such because of the systematic erasure of female sexuality in their education.
That systematic blindness is key. Doctors were graduating from prestigious medical schools without adequate anatomical knowledge of the female body.
Really?
Oh, yes. Medical textbooks show detailed anatomical drawings of male reproductive organs and their nervous pathways, but they were remarkably vague about female anatomy. The clitoris was often omitted entirely, barely mentioned, or labeled dismissively as a vestigial organ, essentially useless for biological function.
They were trained not to see it. Physicians literally graduated without learning that the clitoris was the primary center of sexual sensitivity. They were, in effect, performing a procedure involving the one part of the body their entire education had conditioned them to ignore.
And this treatment, which was designed to relieve nervous tension, it became a massive professional and physical burden for the doctors themselves.
Because of the sheer volume of patients, manual stimulation was causing genuine physical pain for the highly esteemed men practicing it.
We have sources like a Dr. Russell Troll, writing in 1903, complaining extensively about the physically demanding nature of the work.
What did he say?
He wrote that achieving the paroxysm could require up to an hour and a half of continuous manipulation, and called it among the most tedious and exhausting of medical procedures, taxing the physician's strength and patience severely.
An hour and a half? Imagine the scene. A respected, highly paid male physician sweating in his waistcoat in a mahogany-lined office, spending an hour and a half manually stimulating a single patient.
And then having to repeat that process 6 or 7 times a day. And he genuinely believes he is performing a medical duty akin to setting a broken bone. The physical strain became the driver for the next stage of this strange medical history.
The irony is just breathtaking. He was complaining about how much effort it took to manually provide dozens of orgasms per week, yet he framed the issue entirely around his own professional inconvenience. The solution to his physical labor was about to fundamentally change the world.
So the problem of the tired hand would soon lead to mechanization, but we first need to cement the staggering scale of the hysteria industry. By the late 19th century, this was not a minor practice, it was a massive industrialized economy.
Not at all minor. Estimates suggest that at the peak of the Victorian era, physicians estimated that 75% of American women suffered from hysteria.
75%.
Think about that number. 3 out of every 4 women diagnosed with the disease that required regular, often weekly, physical intervention. This guaranteed a huge paying customer base.
And this created massive specialization and enormous wealth. In major cities like New York, Boston, and London, physicians specialized exclusively in treating female nervous disorders.
We know of practices like Dr. Taylor's in New York, which became so overwhelmed with appointments that he employed multiple staff physicians just to handle the volume of female patients, promising complete relief from nervous exhaustion.
And the appointment books, they tell the whole story. This wasn't a one-off consultation. Some women had entries stretching for years. Mrs. Whitmore, every Thursday at 2:00. This consistency ensured massive revenue streams.
And that sheer relentless demand just compounded the physical problem for the doctors involved, making the search for an efficient technological solution, well, inevitable.
The repetitive motion of manual pelvic massage on dozens of patients per week led to severe occupational strain, inflammation, and chronic pain for these busy physicians. The problem of the tired hand was a genuine, documented medical issue for the doctors.
And this mechanical need, the need to relieve the physician's physical burden, is what drove the invention. Enter Dr. Joseph Mortimer Granville in London, 1883.
He was exhausted from the relentless demand for manual pelvic massage, and he sought to automate the labor.
So what did he develop?
Granville developed the peruser, an electromagnetic device capable of rapid, deep vibrations. It was a bulky, industrial-looking machine, often powered by foot treads or early electric motors.
Now, the official record says he initially claimed it was for treating male muscle disorders and general nervous ailments.
Right, but its immediate and overwhelming application was in the hysteria industry.
The efficiency was the selling point, right? Why spend an hour and a half manually massaging when you could achieve the same therapeutic effect, the paroxysm, in under 10 minutes with the machine?
Exactly. This transformed the profitability of the practice, allowing doctors to cycle through many more patients per day.
And the technology spread with incredible speed because it solved a major labor problem. By 1900, dozens of companies were manufacturing electric vibrator models.
Companies like the Weiss Company and White Cross promised the essence of life itself delivered to your very door. The Chattanooga vibrator was particularly popular, advertising itself specifically for relief from hysteria symptoms in under 10 minutes.
Okay, and here is the crucial, almost unbelievable fact about its mainstream adoption that really shows the power of denial. By 1900, the electric vibrator was the 5th most common electrical appliance in American homes.
Get this, the 5th most common.
Think about that for a second. This vibrating machine, designed explicitly to induce what we now know is orgasm, was often more widespread than electric lights, electric irons, or electric fans in many middle-class communities.
It was fully normalized as a necessary household health device.
Sears and Roebuck, the dominant retailer of the era, included a very useful and satisfactory home vibrator in their general catalog as late as 1908.
It was marketed discreetly alongside sewing machines, coffee grinders, and toasters, a legitimate medical device for maintaining female health and vitality.
The cultural belief was so absolute that people could see these devices advertised in women's magazines and household catalogs and believe they were strictly for nervous relief, never once questioning their intended function.
And for the affluent, buying a home device was maybe a bit too gauche. There was a more fashionable, higher-class option than the physician's office.
The hydrotherapy resort.
Exactly, often associated with mineral springs. These were luxury destinations across Europe, places like Bath in England or Bodenbach in Germany, where the treatment was masked in the guise of wellness and relaxation.
But the core therapy involved le douche pelvien, the pelvic shower,
which was a treatment involving powerful jets of pressurized water directed at the patient's genitals while they sat on specially designed wooden chairs. Again, the goal was to induce the paroxysm, only this time using water power instead of manual labor or electricity.
And the advertisements for these resorts were carefully worded, promising complete restoration of feminine vitality and renewal, leading to renewed cheerfulness and capacity for domestic duties.
Patient testimonials confirm this success. One woman wrote of returning home with her spirits entirely restored, and her husband noted a remarkable return to my wife's cheerfulness. The relief was profound because they were receiving regular, professional, medically sanctioned orgasms in a deeply repressive society.
But despite this profound cultural fission, despite all the layers of clinical detachment, the sources indicate that the women themselves, they intuitively understood the relief the appointments provided.
The evidence is scattered, but it's telling. It's often hidden in coded language within historical records.
Like diary entries.
Exactly. Diary entries from the era hint at this private knowledge. One anonymous woman wrote in 1892 that her weekly appointments have quite restored my spirits. I find myself looking forward to Thursday afternoons with great anticipation, though I couldn't explain to anyone why.
They weren't passive recipients of care, they were active consumers. Women actively sought out the best practitioners.
They recommended physicians to each other whose treatments had a most remarkable effect on one's disposition and energy. This suggests they were shopping around, comparing methods, and actively seeking the most effective, quickest providers for this unique form of medical relief.
They knew they felt better, emotionally, physically, psychologically, and they were willing to pay the cost and maintain long appointment schedules to keep it going. They were playing the game, using the medical terminology to get what they knew they needed.
A need that the culture explicitly denied they even possessed.
The entire system was built on a perfect, profitable foundation of cognitive dissonance, an ability to hold two completely contradictory truths at the same time. And nowhere was this hypocrisy more embodied and more destructive than in the figure of John Harvey Kellogg.
The cereal magnate and physician.
Yes, Kellogg is the ultimate example of the era's contradiction. He operated the famous Battle Creek Sanitarium, a massive institution where he employed vibrators, electrical devices, and hydrotherapy to treat hysteria and other nervous complaints in women, promising them healing and vitality.
And at the very same time, he was a ferocious public crusader against the dangers of masturbation, which he believed was a source of moral and physical decay that required extreme measures.
Extreme measures like what?
He advocated for physical intervention to prevent self-abuse in patients, recommending clitoridectomy. And we should be clear, this means the surgical removal of the clitoris, or chemical cauterization for girls, and even male circumcision to make masturbation physically more difficult.
So this is a physician who was removing the clitoris of young girls to prevent self-abuse while actively using a mechanical device in his clinic to stimulate that very region for therapeutic reasons.
And he never made the connection.
Yeah.
He never connected the sexual acts he performed medically with a machine and the self-abuse he warned against.
The same act, performed by a physician with clinical intent, was healing. Performed by a woman on herself, it was depraved.
The difference was entirely context and claimed intention. As long as the man holding the clipboard could claim his intent was professional and scientific, the act remained medicinal.
So what was the first major crack in this system? It came not from anatomy or technology, but from the emerging field of psychoanalysis around the turn of the century.
Sigmund Freud. Now, his views on female psychology were, from our modern view, deeply problematic in their own right.
Of course.
But he introduced an idea that really shook the traditional medical framework. He recognized that women had sexual desires, and more importantly, he suggested that hysteria might be rooted in psychological trauma or repressed emotional experiences.
Stemming from their childhood or their life circumstances, not purely physical dysfunction from a restless uterus.
Right. And this began to shift the therapeutic focus away from physical manipulation toward psychoanalysis and talk therapy. Younger physicians, educated in the new century, started questioning the necessity of physical treatment if the root was in the mind.
It opened the door for them to question the traditional approach without seeming unprofessional.
But psychoanalysis was a slow-acting poison to the hysteria industry. The real, decisive nail in the coffin was not medical theory. It was cultural, and it was crude.
Pornography.
In the 1920s, a new wave of underground stag films, explicitly sexual, illegal content, began circulating in private settings, often distributed via underground networks.
And crucially, these films explicitly showed women using the previously respectable medical vibrators for overt sexual purposes, entirely divorced from a doctor's office.
And this act, being shown to the wider public, instantly transformed the device, The vibrator had always been a sexual device disguised as a medical one, but that dual nature was suddenly impossible to ignore.
The films broke through the highly sophisticated medical pretense, forcing the confrontation of a truth that had been systematically denied for decades.
It's the ultimate moment of public clarity. The implication was horrifyingly obvious to anyone seeing these films. If these devices were being used for explicit sexual pleasure in criminal underground settings,
Then what exactly had highly esteemed physicians been doing in their private lavender-scented examination rooms for the last 70 years?
the speed of the system's collapse is striking because it was driven by shame and cultural panic, not new medical findings.
Vibrators were pulled from the Sears catalog by 1925, almost overnight. Medical journals stopped featuring them, and physicians quietly abandoned the practice of pelvic massage en masse.
What had been standard, common, and incredibly profitable medical practice became taboo almost instantly. The sexual nature of the act could no longer be denied because the cultural context had shifted irreversibly.
The system collapsed not because physicians suddenly realized they were inducing orgasms, but because the rest of the world could no longer credibly deny that the devices were sexual.
So the practice ended quickly in the 1920s. But the diagnosis itself was remarkably stubborn. It lingered in official documentation for decades.
Hysteria wasn't officially removed from the American Psychiatric Association's diagnostic manual until 1952.
1952. It was finally replaced by more specific, psychologically based terms like conversion disorder.
And it wasn't until the 1960s, with the scientific work of researchers like William Masters and Virginia Johnson, that scientific rigor was finally applied to female sexual response.
Their careful observation and physiological documentation confirmed exactly what Victorian physicians had been inducing. The hysterical paroxysm, with its muscular contractions, flushing, rapid breathing, and profound relief, was documented as a textbook female orgasm.
The staggering scale of this collective error is almost impossible to quantify, but we have to try.
You do. If we take even conservative estimates, say, only 10% of adult women in major American cities received hysteria treatment between 1850 and 1920, with an average of 20 sessions each.
The estimate reaches tens of millions, possibly hundreds of millions, of medically administered orgasms.
It's just a mind-boggling number.
This was a massive, mainstream, shared experience for a generation of women whose society insisted they had no sexual feelings. The question isn't just how it started, but how this professional and cultural blindness was systematically maintained for generations right in the middle of a scientific boom.
So let's summarize those mechanisms of denial one last time, because they are a template for how a society can systematically engineer itself not to see a reality that is right in front of it. First, there was educational erasure.
Exactly. The deliberate omission or dismissal of the clitoris in anatomy curricula and the vague treatment of female anatomy in textbooks ensured that doctors were trained from day one to ignore the primary site of sexual pleasure. They literally didn't know it existed in a functional sexual way.
Second, there was the neutralizing power of language. Using clinical terminology, paroxysm, therapeutic induction, hysterical response allowed physicians to discuss sexual acts in academic journals and conferences with total clinical detachment.
It effectively neutralized the sexual reality of the procedure. It ceased to be an act of pleasure and became an act of purging nervous tension.
Third, architecture and protocol. The protocols were physical mechanisms of denial. The covered face, the high ceilings, the clinical tools, the avoidance of eye contact.
These were physical and psychological structures built to ensure that no one, neither patient nor physician, had to confront the personal, intimate nature of what was happening. They transformed a sexual space into a sterile laboratory.
And finally, the professional consensus. Since all respected colleagues were doing it, publishing on it, and recommending it, questioning the practice seemed unnecessary or even professionally risky. The power of peer consensus made the obvious truth invisible, locking the profession into a self-perpetuating, profitable cycle of blindness.
This history reveals just how intensely vulnerable medical practice is to cultural bias. These were educated, well-intentioned physicians, the intellectual elite of their era, but they were so blinded by their cultural consensus, the belief that respectable women were asexual, that they couldn't recognize the true nature of an act they performed thousands of times a week.
And the cost of this denial was often far more harmful than the inconvenience of weekly appointments. This foundational misunderstanding led directly to truly monstrous procedures like Dr. Isaac Baker Brown's clitoridectomies, performed on young girls and women, often without their consent, all in the name of curing hysteria and preventing masturbation.
And he was supported by many colleagues initially because the premise of the diagnosis was never questioned.
And even after the diagnosis vanished, the dismissal of women's physical and emotional pain, she's hysterical, she's too emotional, it's just anxiety, it persisted.
Right. That underlying assumption that female complaints are psychological, subjective, or imaginary rather than physiological remains deeply embedded in medical culture today, a subtle but enduring legacy of the wandering womb theory.
Yet the truth survived, despite systematic erasure. The patient's coded memories, the detailed clinical records of the physical response, the very devices themselves, they remained.
And the ultimate irony is profound. It wasn't a doctor or a scientific breakthrough that broke the spell. Pornography was the crude, undeniable vehicle for the truth, explicit enough to break through the highly sophisticated medical pretense that had protected the denial for generations. Tag outro. We've seen a perfect storm of cultural assumptions, professional consensus, and systematic ignorance that allowed a massive, profitable industry to be built on a fundamental misunderstanding of the human body and the total denial of female sexuality.
The Victorian physicians weren't monsters. They were, in many cases, the most educated people of their era, genuinely following established protocols based on what they believed was scientific fact.
And that is perhaps the most disturbing aspect of this story.
It is that systems of knowledge practiced by highly educated people with genuine good intentions could be fundamentally astronomically mistaken about something they dealt with daily for over 70 years.
They successfully pathologized a lack of sexual satisfaction, gave it a fancy Greek name, and then invented a machine to cure it, all without ever admitting what they were doing.
And this raises an important question for all of us. Where are our current blind spots? What are we in modern medicine, culture, or technology doing today, perhaps regularly and with good intentions, following established protocols, that future generations will look back on with the same utter bewilderment? What cultural assumption are we so locked into right now that it is systematically overriding an obvious scientific or human reality? That's something worth thinking about long after our deep dive ends.
Absolutely. We hope you enjoyed this deep dive into the appliance of denial.